Hi, I'm Saleha, and this is Chai Chat and Community. Today, we are talking about something every parent worries about, those moments when your child is unwell and you're not sure where to go and what to do next. Joining me is Associate Professor Gera, a pediatric surgeon who has spent decades caring for children here in Australia and overseas. He's treated thousands of young patients, taught clinicians, and continues to volunteer in his home village in Punjab to help families who have very little access to healthcare. In this episode, we'll talk about what parents can do, what they should look out for, how to communicate with doctors when English is not your first language, the truth about common child health myths, and how we can support each other as communities raising children between cultures. Thank you so much for joining me, Parshottam. What a pleasure this has been.
Thank you,
Um,
Salas. Delightful to, yeah, no, thank you for having
so,
me.
before we start, I want to hear about yourself.
No, thank you, Salah. The journey started from this small village, Chogama, which is on the Indian-Pakistan border near Amritsar.
Yes.
So after my high school, I did medical school from Punjab and did my general surgery in Government Medical College, Amritsar. And while I was working in Amritsar, the year was 1994. And I think 1995, we were dealing with all adult patients, and one morning we had um, a little baby who was 3 months old and had a green vomits, and they were referred by a pediatrician to our emergency department, and we did not have any pediatric surgeon in town at that time. So we looked at the baby, we didn't know what to do, and we were going to refer him to a specialized center, probably, which is Chandigarh, which is like 5 hours
Yeah.
drive from Amritsar, which is quite difficult for parents to go, and we're just making that call. And our boss at the time, Dr. Bedi from Amritsar, he heard that there was a pediatric surgeon, Dr. Kulwant Singh. He was working elsewhere, but he was visiting his hometown. So we called him, and he kindly came, and he saw the baby, and he suspected this condition, which is a very rare and can be a catastrophic, which is called as malrotation of intestine, where the intestines are not properly sitting in the tummy, and
Oh,
they can
wow.
twist. And they can twist, and when they twist, if you do not operate within a certain time frame, which can be, depending on how bad twist is, can be 6 to 12 hours or 24 hours, and then you can risk losing all your intestines. So we
Never
suspected
heard of
that.
this. Wow.
Yeah. So we suspect, and this is one condition which pediatric surgeon want to be woken up in the night. Now as well, the standing instruction to my trainees are that if there is a child with a dark green vomit, I want to know about it, whether it is 2 a.m. or 1 a.m. I really don't care.
Yeah.
So we took the baby for testing. So there is a special test we do with the imaging, and that confirmed the diagnosis. And we took the baby to operating theater, and I was I got the opportunity to assist the pediatric surgeon, and oh my God, the baby was like 3 kilos, and I was there, and I was seeing how delicate Dr. Kulwant Singh was to the tissues of the baby and slowly working through. And I was just amazed. And I think that day it hit in my head somewhere that given a chance, I will want to become a pediatric surgeon one day. And I finished my training in India in general surgery in 1998. Got married. Mala, my wife, she's a pathologist in Perth here with me. So we started living in my village, and started working for the community there. I was posted as a general surgeon um, just near the border, Indian-Pakistan border, for a year and a half. But that thing in my head that I wanted to be pediatric surgeon was there. So then I got an opportunity to train further in Mumbai, and I went to Mumbai in 2000 to train in pediatric surgery. Did my full training there, worked there for a year, and then got opportunity to come and worked as a fellow in Sydney. And once I come, I saw how beautiful Australia was, and the work-life balance, and the parents with the blessings. I tried to get in the training program here. It was few hiccups. Ultimately, I
Yes,
got the training
we know,
program,
we both know.
and it was kind of challenging to start with, but took few years, and it was excellent experience to train in two continents. One had a big volume,
Yeah.
India, and one had a structure, very firm structure, and you test like I called as you train them until they polish them that much that you are like a diamond, and then the surgeons come out. So by the time I came out, I thought I was well polished. So in 2012, I became a pediatric surgeon, fully qualified FRSES, and then joined Perth as a consultant after my training in Sydney. So that's nutshell, and it has been now 14 years as a consultant in Perth, working in public and private. So fantastic. So yeah,
So, one 3-month old baby with green vomit is when you decided you needed to be a pediatric surgeon, and that's what
still
still keeps
remember
you
that
going.
morning. Yeah, still remember that morning in 1995. Yeah,
Wow. That's more than 30 years now.
yeah, exactly. That was my first pediatric surgery case where I scrubbed for. Yeah.
So, we talk, well, obviously, this is for parents. So, when you meet anxious parents in hospital, and I can imagine, especially when the baby is sick, what do you think they should know, or what would you wish they knew?
So look, it's very interesting that we in Australia, it's fabulous here. And I will give you example to start with antenatal care. So I run antenatal clinic here, and I go, you know, most of conditions here, congenital condition, the surgical, where the children are sometimes born without food pipe, without bum holes, um, with some significant lung issues, or some intestinal issues we can diagnose antenatally. So at 23, 24 weeks, even before, with the fetal scan they can diagnose. And every state has got a specialized unit where those patients get referred. And then those patients who have surgical problem get referred to surgical cases, surgical specialists. So whenever there is a general surgical issue, we as pediatric surgeon get the referral of that antenatal case. So I go and see those parents, or my colleagues go. So I go every month to see those antenatal cases. So imagine a child is, we know that this child is going to have significant intestinal issues. So we kind of tell them how their journey is going to be. So it starts with their
For the
demographic.
rest of the child's life?
Yes. First to start
So,
with the short term and long term. So some things are short term. So you fix them and they are good as a gold, and they don't require any further long term follow up. But there are some issues where we have to follow them up till 16 years. And that's the time to build that trust with them, to take them through that journey. So start with demography, where they live now. So, during the first initial treatment, how long the child is going to be in hospital, what will they need, what kind of family support they have. And we take them through that journey to see what's going to happen with that baby so that they can mentally prepare for it. So, one cause of anxiety is not knowing where this is going to lead. And parents are not, looking at, and especially, when we have a young child, the parents are young themselves as well. So, they have new jobs. They might not have family support. They might be away from their family. Somebody from Melbourne is in Perth and they don't have their extended, or they have other children to look for. And when the child is hospital, so we got constantly see, parents are struggling. So that's the most, so if you can give them a road map, a rough road map, So, for example, when I do a laparoscopic appendicectomy, and first question is, how long will be in hospital? So I will say anyway in between 2 to 6 days or 2 to 5 days, if everything goes well, which goes well in more than 95% cases. But there might be something, and if there is something, I will let you know. So it's a constant ongoing communication, and the end result, if you communicate them, that kind of anxiety, that will lower their anxiety. And that's where the communication is very, very important in, in that scenario of not knowing where it is leading up to.
Wow. It's actually very scary. Yeah, I remember when my daughters were sick, and as you said, we are all young parents. We were all young parents at one time, and parents are young, and especially for migrant families who don't have the extended help, extended family to look after. And if you have two other children or even a child who's a toddler, I mean,
It's
it's a
really difficult,
huge,
like
very difficult.
it just throws a spanner. They have not planned it. This suddenly came onto them, and and it's really, and sometimes they are kind of, they have just come to new country, they're still figuring out what to do, where they're going to live. And then if they have some complex issues, there are more than one team is involved. So I might have a general pediatrician, I might have a respiratory consultant. So they're hearing like three, four people constantly telling them the information. So if there is no overarch and you combine them, and in these cases sometimes we do multidisciplinary meeting and invite parents so
Yeah.
they can get one information from everyone at one time rather than getting this bit information from there and bit from there.
So this is something that I ask all surgeons and doctors I speak with. When English is not your first language, how do you communicate?
It's
And
very,
there are
very,
many, there are. I mean, um, I have heard people get their permanent residency, or the right to work, or sponsored work, and they come and their wives are pregnant, and the wife is 4 months pregnant or 7 months pregnant or whatever, and they've left everything behind to build a new life with a child on the way, and when the child comes they may have a lot of issues. So
it's very vital. And I think for it's a message for our people from subcontinent that if you can't understand something, let them know. So sometimes, from our cultural background, we think that asking a question might be rude.
yeah.
So if you have a clinician or somebody giving you information and you don't understand, tell them to, I don't understand, please, can you help me out? And for doctors, it's vital important that they ask patients as well that are you understanding my information? And one of the very, very vital thing is that when we do consent, not only asking patient that have you understood, asking them repeat that information in their own language or English if they know that, to make sure that they have understood all the information are provided. I think example will serve here better.
Yes, absolutely. And I wanted to ask you another question for people who don't understand English.
So I had a patient few years ago, a patient from African subcontinent, a very complex situation with the child will require a couple of surgeries staged. So I was handed over this patient and I was told, as sometime I always say to my trainees, sometimes they say, oh, this is a difficult parent. And I say, please don't use this word. It is a parent in a difficult situation.
Situation, yes.
Okay? So you need to help them out. They are not difficult, they are in difficult situation, and hence you need to go to their level to understand why they are having those issues. So I was again told by someone, oh, this is a difficult family. They are not consenting. So we called them. They needed an interpreter. We called the interpreter. We went through all the operation and we just couldn't get through. Like they kept on saying, we will think about it, we'll come
Yeah.
back. And this was a child was going to have repercussions of the surgery. And And I was also thinking, we have an interpreter, we have everything. They're just not committing to it. What's the hiccup? And there was only one question. We will consent for it if you tell us there is 100% it's going to work.
which you can't.
Which you can't. So I said, look, let me do one thing. I said, what language they had? They had some sort of
Yeah.
African dialect. I said to my staff, I said, look, this is the information I have. This is the risk. This is their trajectory for next 15, 16 years. Can you get this in their language? And we got it for next week. When they came, I gave them. I said, look, take this home, read it. I'll have another meeting next week. And next week, there was no issues. They just couldn't take the information through the
Yes.
interpreter as well. Once they had the information in their own language, sitting with them in a week, they could reflect on it, they could discuss in the family. And child is now 15 years old. I saw him only a few weeks ago. He's doing okay. He's in year 11, I think. So, yeah.
So, Parshottam, when you talk natal and antenatal, what does it mean?
Yeah. So, antenatal is the child is not born yet. So, we have diagnosed a condition when the child mom is still pregnant. So, we have a condition, we call it as a gastroschisis. It's a Greek word. Gastro means gut,
Yeah.
and schisis means cut. So, these children are born with the intestine outside their tummy. So, we get around 10, 12 children every year in Western Australia, almost 100%
Is it
survival.
common?
One in 5,000 births. So, and the main critical factor is that we get all those moms to deliver in our tertiary hospital and then transfer to the surgical unit on the same day and start the treatment same day.
So when the child is like a few hours old?
Yeah, few hours. Yeah,
Whoa.
yeah. So and when I go to India for conferences, because they still like stringent antenatal care is not there. Children can born anywhere. Sometimes they don't have antenatal scans. These children have high mortality. They don't survive. And I have seen when I was training there that these children will die due to infection because the intestines are outside. But with our excellent neonatal care our colleagues provide in the NICU unit, our excellent nurses in Australian system, we have almost 95 to 99% survival. And it's one operation, and most of these children do very, very well. There's one footy player, in fact, who had gastroschisis from Melbourne. You can Google his name, it will be somewhere there. I don't know who it is.
Oh. Um,
Yeah.
Question for all of us parents. What are the three simple things that parents can do to keep their children healthy?
I
I
will,
mean, I mean, if a child is born with everything that you have said, there is nothing. Green vomit, I have to remember that. Green
that's a
vomit.
critical in pediatric surgery, green vomit. So if it is and I show them like dark green, if it is, then it is we always say it's surgical unless proved otherwise. Uh, Look, I say a healthy child should eat well, poo well, and wee well. So three critical things. If a, if a child can do these three things, there is mostly they're fine. Okay. With the healthy things, like you need to kind of feed them healthy, of course.
Of course.
They give them healthy food, nourished food that they can grow well. Um, they parents worry about few things which um, you know are of course these days critical, and we um, I want to address it. One is the digital health.
Oh my
So,
God, yes. Oh my
so
God.
I think we all have to look at the screen time for our young kids. That I was the internet was not that common when my children were growing up. They're
Yes.
both now finished their uni. So
And one a doctor.
both, yeah, both are
Both are
doctors.
doctors.
So they're just junior doctors now. So they also had phones, but when they went to school and all, they didn't have data to go
Yeah,
on the internet, and it was quite restricted at home as well, the screen time. Um, I think my son was like, when he wanted to play video games, it was like 2 or 3 hours a week. So that was what the time. And I think now I see children coming to outpatients and little distraction, and the phones are out. And it's difficult to have that conversation. And it affects everything. It affects their attention, it affects their mental development, and of course, everything else in the life. So I think one main thing is to uh, look at their well-being is digital health, and third thing is uh, leading by example. I really believe that if you want your child to do something, then you have to lead by example. So if you want them to eat a certain food, then you need to
yeah.
eat
You
the
have to be
same
the role
food and
model.
the table and the model. If you eat something different and ask them to do something different,
Yeah,
it's not going to work.
well,
So,
absolutely.
so I think these are the few things. And third most thing, I read a book recently, which was how to develop resilience and grit. And that was one factor they had identified in children, or people who were successful, was resilience. And I think resilience comes with a bit of discipline. So if you have something, a discipline of sports, study, eating healthy, that certainly takes you a long way.
Yes. Um, some myths about children's health that you often see in our community.
Yeah, so one is, I'm not a immunologist, but I see a lot of myths about vaccination, that um, vaccination, vitamin K, they can cause this. I think these are all myths.
That's how I started my podcast about vaccination,
Yeah,
because in our community, everybody
yeah,
has got an opinion, and
yeah.
yeah,
So I
it'll do
think
this and it'll do
vaccinations are,
that.
yeah,
Yes,
I think it's very vital to immunize. And I think we have not seen, but I have seen in India children who had polio. My
yeah,
own cousin's sister had polio. I think there was some delay in her vaccination due to some issues at that time in India, and they couldn't immunize her properly, and then she got polio when she was very, very young. And we could see her journey in the life, the challenges she had. I remember as a child when uh, smallpox was
yes,
getting eradicated, and we had posters all over India that you bring case, and I could still remember people who had smallpox, that their residual scars and everything.
yes, absolutely.
And things have changed, if we see how we don't see polio, we don't see these diseases, and I have seen rabies, which has got 100% mortality. I have diagnosed in my career 3 cases of rabies who died
This is
in.
in India.
Yes.
Yeah.
So their first symptom is like, getting fear from the water. And these people
Oh,
didn't have anything run wrong. They were just bitten, and they didn't get, they were not aware. They're not that they were against vaccination. They were aware. And by the time the thing set in. So I always say that, very careful, even if you're going overseas, in a country where we had a friend traveling to some Asian country, and he thought that he was bitten by a cat there, or a dog. It was, I think, dog. And then we advised him to get vaccinated immediately. So I think, even those kind of things. So you need to um, look at it. Preventive side of things is very, very important. In young children, you people say sometime, diarrhea happens due to teething. I think it is not due to teething, it is due to the infection if they're putting wrong things in the mouth. So that's one of myths again, that teething does cause irritation, so child keep on putting things in the mouth, but it won't probably cause um, diarrhea.
Gary.
And the last thing is about antibiotics. I think we, coming from India again, if you have a cough or runny nose, and first thing
Yes,
you do is
always. Yeah.
antibiotics and give cough syrups and antibiotics. Cough syrups are not needed usually in children. You don't want to suppress the cough. It's a symptom, it's going to go away. And and antibiotics are not needed unless it is leading to it's a really infective course. So if the child is unwell and you're worried, go to your GP and or go to the nearest hospital, but don't insist on taking antibiotics if your GP or your doctor thinks that it's not needed.
Yeah. And here, GPs normally don't prescribe antibiotics at
Yeah,
all.
no, that's
Yeah. Yeah.
I'm addressing, sometimes I
Yes.
get
So,
from the
yeah,
community, Dr. Gera, we went to your GP, they are not giving us antibiotics. If we would have been in India, it would have been given.
absolutely. I agree.
And the resistance against antibiotics in India is massive. Personal experience. We are still using as surgeons the antibiotics which we used to use in 80s or 90s in India. And they still work here, but not in India because we don't have a prescription model there, so people can just take antibiotics from chemist
Yep. Over the
and
counter.
over the counter. So you
Yeah.
don't have full course. You do
Yeah.
whatever you know. You
I'm
know.
guilty of that. I had a terrible cold when I was in Delhi, and I just went to the chemist, and in like less than 2 hours, my cold was gone,
But
which normally shouldn't happen. It should take
but
its course of
I'll
7 days.
just there's one message here. I know a lot of people from friend circle who bring a lot of antibiotics from India, because GPs is not prescribing it here, and so
Yeah,
take it at when they need it. I don't think that should be done. You should be going to your GP and then thinking about antibiotics. So I think these are a
absolutely.
few common myths. And about the surgical condition, I will say if you are worried about your child, get him assessed. Any lumps, bumps, look, with which you have in children, we common conditions we see is kind of inguinal hernias or some testicular issues or
As in a child,
yeah, yeah, we see a lot of issues with hernias. We like testicular torsion is quite common in kids with the
what is
testicles.
that?
So, boys are born with two testicles. So
Okay,
they
yeah.
can sometime born in a way they can twist. And if
Oh,
they twist, then they can cause a lot of pain. So it's kind of it can happen at any time, but more common in post-pubertal boys.
so
Uh,
15, 16.
yeah, like no, 13, 14, but it can happen at any age. There's no age which is immune to kind of testicular torsion. And when it happens, it causes acute testicular pain. It's kind
Oh,
of very, very severe, which which can which is out of 10 pain. So if you're worried, you have to be assessed by a surgeon. Yeah.
okay. So now we come to my favorite part. Your volunteering work, so inspiring. And you continue to volunteer in your village in Punjab, and how has it shaped the way you care for families in Australia? I remember this is one of the questions I sent you for the magazine also.
It's very humbling, I tell you. It's very humbling when you go there and when you come here. It's uh, you probably can relate to it, but if you've not seen that, you can't relate to it. So it's when you go there, so I'm there for 1 or 2 days. You have these swarms of patients. Last time I was there, I saw, with the help of another volunteer doctor, 250 patients in a day. We were just, patients were coming. And like I was saying, look, I'll stay in one more day, but people like, they have common conditions and the resources are limited. A lot of people, like, although the city is only 20 kilometers from that village, they probably have gone once or twice in their life to village, from out of the village. Their life is there. And people are poor, like they are earning maybe $2 or $3 a day, which are going towards their food,
Just
whatever
survival.
survival. And if they don't have money, like only yesterday, like because we are running now monthly clinics there. My sister is there, so she's supervising. She's non-medical, but she's supervising with the help of another doctor there. So she said, oh, she has this patient whose blood sugar was 4 times normal, and she knew she's diabetic. And I said, is she taking medication? She said, oh, she says she buys it when she has the money. And and you can see the diabetes and the hypertension and many other things like common, like things which people are ignoring due to lack of resources. Then you come here, and I'm in theater. Now I'm going to operate, and I say, I need this. And it's opened, no question asked. I need this is stapler to be used. And then I reflect when I practice there that, do I need this equipment? Can I save something here? Because that mindset is coming here. And now it is more important because recently I was attending this whole thing about the sustainability now with in medicine and
Yeah,
equipment and
yeah,
everything,
I know that. Yeah,
greenhouse gases. Australia and America are the biggest
biggest
producers
house. Yeah,
in medical. We don't care
yeah. We
basically, but
don't
now
even
we've
think about
started
it.
caring. Now we started caring. So we have a sustainability project going in our hospital
Yeah,
where we're trying to recycle things. India and China is the biggest recyclable medical products. So that's another resources. I tell my trainees still now when I started my training in Amritsar, when we were doing open appendicectomies, that time, you didn't have the laparoscopic, still it is 1994. We were given two sutures to do the whole operation. So if you ask third, your nurse will raise eyebrows at you. Are you wasting money of patient? Is he's going to cost another 100 rupees to the patient?
yeah,
Aren't you a bit stingy? So till now, sometime I have a suture, I'll try to go through the last bit of stitch to save that extra suture. And the staff will say, why are you to doing it? I said, look, this is a habit. So, and it's saving something. And to see those people here there and the volume and how they, I think that there is a population here as well which we need to address. There is a gap we need to fill up in our community as well. There are disadvantages communities. There are parents who are struggling, and then when I have seen those things here and I see sometime, those same things coming here, then you reflect on it and then you get help of, for that parent in difficult situation, not a difficult parent, to
yeah.
help them in whatever way you need. You get involvement of a social worker, you get some Aboriginal liaison officers to help and see if you can care them close to their home, what resources they need. And we don't have lack of resources, but we just need to point those resources in the right direction that they can get the optimum outcome. It's very humbling. It's really humbling that
I can imagine. So, what have those health camps, in both in your village and working with indigenous people here? How has it affected you?
look. It just like in Gurbani and in spiritual. I belong to a group, the science of spirituality. Um, and I've been like, in our Indian temples and mythology. It's a selfless service, a service which is done without any expectations. And and it's kind of a giving back that if I have taken the liberty of train myself, and with all the support I had from people around me, it is my time to give back something to the community. And if I have I'm in a position there where I can help. I should be helping, and that gives me a satisfaction which is beyond any happiness of any material things when you have made a difference to one person, and that person, when 1994 I started working in my village. My dad was GP there, and he kind of handed over that clinic to me on Sundays when I was training as a junior doctors. So I feel very humbled when I go back into that village. How many years now? 1994 to 32 years.
32 years.
People still remember. The people I operated on 32 years still come and meet me.
Very humbling.
It's like, oh, they will like show me their scars. You remember me? I said, I'm so. So it's like, it's really, really, it's touching that, you can feel that love because, and it's the same thing here. You've done something for a family. Like I was telling somebody the other day, we have a South Perth area here, which is right on the river. So one morning I was coming from someone and I said, I'll just stop here for a coffee. I was alone and I was walking, and suddenly a child came running and in between my legs. And I said, I'm sorry, he was like 6-year-old child. And then I turned back and this mom said, Dr. Gera. I said, okay. So she said, oh, you have operated on him when he was baby. Like I think that kind of experience is beyond anything when you get that love, and you made a difference to someone and they
Absolutely.
remember you.
I can't even fathom, but yes.
Yeah.
Um, this is something that I think you and I have spoken about in our magazine. AI in healthcare. What is it that, you know, parents of young children, and I'm talking about since till about say 16 or 17 should know, and what is the one myth that you want to dispel? Because we keep hearing AI in medicine, and will surgeons actually operate, or is it going to be robotics? I don't think people still understand the robotic surgery part of it.
Yeah.
But what is the one thing that you can say that will put parents' mind at rest about AI in surgery?
I think the doctors are looking at it very carefully.
Yes,
They need to assimilate into AI into their practice. So I'll give
and
you
that's the way of the world.
a
AI
couple
is
of
everywhere.
examples. So, like appendicitis is a very, very common condition
Yep,
in children. We do many appendectomies a year, maybe 500 a year in our hospital.
yep,
And it's a common condition. Still, sometimes it is very kind of tick all the boxes, sometimes not. Now, with the AI tool, if you put those, yeah, a doctor puts those particular symptoms and blood test and all, that gives us a probability of appendicitis. So we can score. So we've done that tool now in our emergency. When a patient comes, a doctor looks at the patient, do the scoring, and then look at the probability of appendicitis, and then see if they needed further investigation, operation. Of course, the clinically they need to assess the patient, but that
of course.
score helps them in the diagnosis because we do not want to remove a normal appendix. We want to
Absolutely. Yeah, yeah, yeah.
So we want to be 100% certain when we want to operate on a patient. And that gives us, is helping us in that. But that is like a judicious use of AI in medical practice. Now, the other thing is for the doctors, a little AI scribers have come now. So,
Yes,
doctors used to, it's not in public, it's not licensed, but a lot of private doctors are using it. I'm not using it yet. So that you come in and your whole conversation with the doctor is getting recorded, and then it comes in a letter. So it's decreasing their workload. They're
yeah.
not missing any information, and it's again
So the
helping.
admin part is taken care of.
Yes. Now, third comes the robotic surgery.
Yes,
Now, It's going to come. It's going to come in a big
It's
way.
already come.
Instruments gets a bit more cheaper. It's not come in pediatric yet. We are
Yep,
trying.
but in orthopedic, I know it's come.
Yeah, in pediatric, because in US and India it has come in pediatric in China, but in Australia because of the low number of volumes, it's not there in public hospitals, and I don't. I think maybe one or two hospitals in Australia they are doing it, but not. It's not that much common yet. Now, what? How I did spend some time in Chicago on a robot for a couple of weeks in a laboratory. So it's like a gaming console. So imagine that first thing is again, so if you are doing a tummy operation, a doctor has to make a cut on the tummy,
Yeah.
put the instrument in, and when you do keyhole surgery, it's a keyhole surgery. So when I do appendicectomy, I put three holes in the tummy, little 5 millimeter holes. And there are these plastic sheets which go, and then we put through the instrument and look at the picture and operate. Okay, that's laparoscopy. Now, when you do robotic, you still need to make those three holes. And you need to be very careful, especially in children, when you make those holes that you don't injure any organs. So that has
Yes.
been done by a specialist surgeon. So you make three holes, you put the instruments in there, and those instruments are hooked to the robotic arms. And now those robotic arms are hooked onto a console. Now you are sitting on a chair and there are two knobs there. So you are holding those knobs, and as you move those knobs, those consoles, they are moving the instruments. And it's a precise movement, and that image you are seeing on the screen is a 3D image, which has a big resolution. So in laparoscopy, when you do, your movement is 180. Our wrist is 360. In robotic, your movement is 360. So you can rotate the instrument how you like to. So if you need to put some stitches in the tummy, this is a bit easy when you do when you do with the robotic. So surgeon is still there. Now the next phase which
And still controlling.
yeah, next phase which is not, I don't think it's coming very shortly, but it will probably come at some stage. So they will teach robot to do the operation, like they are teaching pilot to do fly the
Autopilot.
plane. But then pilot is still there.
Yeah.
Like you can a common appendicectomy if you put millions of things in AI and you see and robotic arm can go and find the appendix and take it out. But that's going to be a risky proposition. But still, like, you have not flown the planes without a pilot. Pilot is still
Yeah.
there.
Absolutely. Yeah.
So, and the third thing in robotic is a telesurgery, which is getting quite common in China and India, where one surgeon is sitting maybe thousands kilometer away, and patient is somewhere else with another surgeon, and you are operating from here, while of course there is another surgeon helping and overseeing the part, which might be useful in future with highly specialized surgeries, especially in Australia if it comes, like you have a
Remote regional areas.
remote
Yeah.
regional area and you're doing a complex surgery, you don't have a highly specialized surgeon,
Yeah.
but that surgeon is sitting in Perth and trying to supervise. So
Yeah.
that will
It's
have,
already happening in Queensland.
yeah.
Yeah. So yeah, for remote regional, I think this is going to be fantastic.
So it started with the military actually when they
Oh,
started in US. It is very strange. In 1994, I attended my first conference of my life in Delhi as a surgery conference, and there was a talk on robotic surgery.
in 1994.
And I remember that time was not a robotic like laparoscopy. That time was a robotic arm getting devised. So robotic arm was a theory was that the surgeons, when they get old, they get tremors. So they might have some sort of a arm to control their tremors. And then the first robotic thing was only a camera. We have a laparoscopic
Yeah.
camera. So in Mumbai, we had a surgeon from US who showed us a robotic camera in 2000, and his camera was voice controlled. So he was operating laparoscopy, but the camera was controlled by his voice. So he was doing a gallbladder, and his camera was known as Lucy. So he'll say, Lucy, come in, go back, right, left, and he finished the surgery. And he had put a verbal message in there. Once surgery is finished, he said, I'm finished. And he said, Dr. Loeb, you are a fantastic surgeon. So it
How
was,
much things have changed in the last
yeah,
25 years.
yeah. So that was 2000 in Mumbai. I saw my first that robotic arm surgery when I was there. Yeah.
Um, One piece of advice you would give parents listening today about their children's health?
I think I will just say keep them healthy and keep them close. A little babies, their most safe place is with their parents. So, and if you have any red flags that, you're thinking, you're worried that the child is not feeding well or have any concerns, just go to your health professional. But if they're eating well, they're growing well, and they're playing and they're doing all the right boxes, just keep them close and keep them loving. That's the best place. They need a little bit of discipline. So I always tell my friends that if your child is asking you something, if you're going to say yes, say first time. If you
Yeah,
said no to something, then stick to it.
absolutely.
Don't give up on tantrum.
And we always do.
Yes, try to not, because their limit is going to increase every time. They're going to push your boundaries.
Yes. Thank you so much for joining me today, Parshottam. This has been amazing. I did not expect this to be so good,
No, thank you,
honestly.
Sagar. Thank you
So,
very much. And I appreciate your
and
time. It was beautiful. Yeah. And I
and
feel
if you are
comfortable.
a parent listening, please do listen to the whole episode because Parshottam has some really good advice for you and he's also dispelling a lot of your fears. And I just hope our conversation reassures you that you're not alone, that there are caring clinicians and surgeons like Purushottam out there who genuinely want to support you and your child, no matter your background, your language, or your circumstances. And if you found this episode helpful, please share with another parent, another family member, or someone in your community who may need it. And as always, thank you very much for being part of this space where we learn, grow, and support one another. Thank you so much, Parsutam.
Thank you so much, Sagar.
Okay,
Thank you.
okay,
Thank you.
bye.
Bye.